Hey, welcome back, and I want to thank you for your punctuality. That was a joke. We're running 10 minutes behind schedule. All right, hey, for those that have been asking on the technical issues, a couple of things. Number one, are we having some great information that's available to us or what? Absolutely. And the good news is all of the material, the slides, et cetera, all of that's going to be available. If you registered, we'll get it to you. If you need to go and acquire it for yourself, you can do it at rcbo.org. Those slides will be available for you to download and to send on and to social media, tweet and Facebook post and whatever you need to do to help get the word out on this. So the slides will be available rcbo.org. Also, if you're having difficulty getting the live stream on your mobile, don't worry. We're having a technical issue on the mobile streaming only. Anybody that's watching it at home on a PC or on a laptop, they're getting the feed no problem at all. But for some reason, we're having difficulty on the mobile feed. But other than that, we're in pretty good shape. All right, let's get right back on the schedule now. I want to take this moment to tell a little bit about our next speaker. Aaron Kheriaty is an associate professor of psychiatry and director of program in medical ethics at the University of California, Irvine School of Medicine. He serves as chairman of the Clinical Ethics Committee at UCI Medical Center. Dr. Kheriaty graduated from the University of Notre Dame in philosophy and pre-medical sciences and earned his MD from Georgetown University. He lives here in Orange County in San Juan Capistrano with his wife and 5 sons. He's the author of The Catholic Guide to Depression and the editor of the classic True or False Possession, How to Distinguish the Demonic from the Demented by Jean Lermite. Here to share with us on the topic of psychology of suicide and pitfalls of assisted suicide, please welcome Dr. Aaron Kheriaty.
Thank you, Mark, for that kind introduction. Thank you all for being here today. The purpose of this conference is to move all of us into prayer and into action. I was up in Sacramento a couple of weeks ago, testified at the Senate Health Committee hearings on SB 128. And we had a decent showing, but we could do better. So when this bill goes to the floor of the Senate and the Assembly, I expect all of us will be busing ourselves and our friends up to Sacramento to be outside the Capitol. Senate Bill 128 is actually the 4th time that such a bill or a ballot measure has been proposed in California over the last several years. Each of the 3 prior attempts, as you probably know, was defeated. The public is clearly not sold on the idea of assisted suicide. This bill follows failed attempts to legalize this practice in 4 other states last year and in 2 states already this year. Most recently, a bill was defeated just last week in Maryland. It died in committee. So I think the first thing I want to say is that we need to resist the sort of air of inevitability with which proponents of assisted suicide are trying to frame this debate. You know, this is coming and you're not going to stop it. We can stop it if we get moving. The American Medical Association's official policy on assisted suicide succinctly summarizes the problems with legalizing this practice, and I quote, "Physician-assisted suicide is fundamentally incompatible with a physician's role as healer, would be difficult or impossible to control, and would pose serious societal risks." Now, in my brief remarks today, I want to sketch 7 reasons why we should vigorously oppose Senate Bill 128. These are reasons grounded in medical ethics and scientific research. So these arguments can be understood and appreciated by any person of goodwill, regardless of their religious convictions. For our fellow Catholics, let's go to them with the theological principles that Father Joseph just articulated. For non-Catholics, non-Christians, we have very sound, very persuasive and compelling arguments that we can use. The problem is, so far, this debate has been dominated by one single narrative, in fact, by one single case in the media. Right? And so we need to move outside of that and look at all the people that will be impacted by this kind of law. Now, as a psychiatrist, I see patients routinely who tell me that they want to die, who demonstrate suicidal thinking and behavior, people whose life stories are every bit as heartbreaking as Brittany Menard's, and whose reasons for wanting to die might at first glance appear to be just as compelling. But suicide is nearly always a cry for help. It's not a desire to die. And so as a medical professional, I have a duty to intervene to try to prevent suicidal persons from taking their own lives. These interventions are grounded in the foundational principles of medical ethics, because our profession exists to heal the sick and to support whatever life the patient has left. As we just heard, medicine need not extend life at all costs. But for a physician to directly take life, as SB 128 proposes, is to violate the first principle of medical ethics, to do no harm. And so reason number one, physician-assisted suicide runs directly contrary to the principles of medical ethics. It contradicts our role as healers. A law allowing assisted suicide for some individuals basically creates two cohorts of patients. Patients who no longer enjoy equal protection under the law and who no longer receive equal medical treatment. Assisted suicide is therefore discriminatory, and the basis of discrimination is the patient's health status. So Robin Williams walks into my office saying that his life has become unbearable, and so he wants to take his own life. And naturally, I intervene to protect him, to get him through this crisis. Then Brittany Menard walks into my office saying that her life has become, or she anticipates will soon become, unbearable, and so she wants to take her life. And not only do I not intervene to protect her, but I actively engage in helping her to kill herself. These two incompatible approaches to suicide can't coexist side by side within medicine and mental health care. Something will have to give. And so reason number two, the legalization of physician-assisted suicide for some patients introduces discriminatory practices into medicine. It undermines patients' equal protection under the law and weakens necessary efforts at suicide prevention. If there exists a right to assisted suicide, why would it be restricted to only those individuals in the throes of a terminal illness? What about the elderly person suffering a slow but non-terminal decline? What about the adolescent or the young adult in the throes of depression or demoralization or despair? Once we adopt the principle that suicide is acceptable, that it's a reasonable response to certain adverse life circumstances, then the fences that legislators might try to erect around it, having 6 months to live, having mental capacity, being over the age of 18, these things are inevitably arbitrary. And so these restrictions will be abandoned in the face of legal challenges. We see this with assisted suicide in countries like Belgium and the Netherlands that have been practicing it longer than places like Washington and Oregon. I'll cite just a couple of examples. In Belgium, assisted suicide has been granted to a man who had, quote, untreatable depression, but no medical or terminal illness. It was granted recently to a prisoner suffering what he described as psychological anguish due to his imprisonment. In the Netherlands, assisted suicide has been granted to a woman because she did not want to live in a nursing home and she had no other housing options. And so we see evidence here not only of a practical slippery slope, this notion that the restrictions are going to be difficult to monitor or to enforce. More than this, we see a relentlessly logical slippery slope. Because once we accept this principle that suicide is a reasonable response to difficult life circumstances, then these restrictions become arbitrary. So the expansion of assisted suicide moves inevitably, inexorably, from a cancer patient with 6 months to live to individuals who are merely dejected, depressed, or desperate, who have inadequate social support. And so reason number three, the legalization of assisted suicide will lead to a relentlessly logical slippery slope. Restrictions will inevitably fall away in the face of legal challenges on equal protection grounds, right? If you're going to offer it to this person, why wouldn't you offer it to me? After all, I'm suffering more, right? They're going to die in 3 months. I have to deal with this illness for the next 3 years. So the range of patients and circumstances in which this is applied will expand. We see this already in Oregon with the introduction of a bill just a few months ago to expand the requirement from 6 months to 1 year. So that's going to be the first step in this kind of logical progression. Suicide is now a public health crisis. Suicide currently constitutes the third leading cause of death overall for adolescents and young adults. I'm going to say that one more time. Suicide is the third leading cause of death for people in their teens and their 20s. It's the 10th leading cause of death for adults overall in the United States. And so I think it's important in the context of this debate to examine what the research shows about suicide. Right? What motivates suicidal behavior, suicidal thinking? What kinds of people are at risk? How can this risk be lowered? We know, for example, that suicide is typically an impulsive and an ambivalent act. Right? The person doesn't really want to die, they just want to escape what they perceive as an intolerable situation. A journalist tracked down the few dozen individuals who had survived jumping off the Golden Gate Bridge. The Golden Gate Bridge to the north of us is the #1 suicide spot in the world. Over 2,000 people have died jumping off the bridge, about 1 every 2 weeks since it was built. Very few people survive, but a handful have. And this journalist tracked them down and asked them, what was going through your mind in the 4 seconds between when you jumped and when you hit the water? Every single one of them said the same thing. I regretted the decision to jump. With one man saying, quote, I realized that all the problems in my life that I thought were unsolvable were actually solvable, except for having just jumped. Now, this small sample of suicide survivors is consistent with larger studies that in the months or the years following an attempted suicide, the vast majority of these people no longer want to die. They're happy to be alive. And they're grateful to the physicians who intervened to protect them, even when suicide prevention measures took the rather radical step of things like involuntary hospitalization. Another study from professor at UC Berkeley tracked down 500 individuals who were stopped prior to jumping off the Golden Gate Bridge. 25 years later, 94% of them were still alive or had died of natural causes. Only 6% went on to take their lives. And so to abandon suicidal individuals in the midst of a crisis, in the midst of a newly diagnosed devastating illness, to do this under the guise of respecting their autonomy is socially irresponsible. It's a form of abandonment. As I said, suicidal individuals typically don't want to die. They merely want to escape what they perceive to be intolerable suffering. And those who work in palliative care, we'll hear from my colleague, Dr. Nguyen, later this afternoon, those who work with dying patients will tell you that every time a terminally ill person professes that he or she wants to die, this is a cry for help. Right? This is a plea for assistance, for compassionate care. And when comfort or relief is offered in the form of more adequate treatment for depression, better pain management, more comprehensive palliative care, fellowship and support in the patient's last days, this desire for suicide vanishes. We know that the vast majority of suicides, as Father Spitzer mentioned, are associated with a clinical depression or another treatable mental disorder, including, the research shows, including for individuals at the end of life. Yet alarmingly, only 5% of the individuals who have died by assisted suicide in Oregon were ever referred for psychiatric or psychological evaluation or consultation. This number also is decreasing every year, getting less and less. Just like the Oregon law, Senate Bill 128 does not require physicians to refer for psychiatric consultation to rule out the most common causes of suicidal thinking, the mental disorders that contribute to people wanting to end their life. And considering what we know about suicide risk factors, well established scientifically and medically, this constitutes gross medical negligence, right? Another form of abandonment. Now, suicide completion generally requires not just intent, but also easy access to means. This is why suicide barriers on bridges, they still haven't put one up on the Golden Gate Bridge, do actually save lives, measurably save lives. Right? Because suicidal individuals tend to fixate on one specific plan. I need to get that deadly drug from my doctor. Right? That's my way out. If this particular means isn't readily available, they typically don't choose an alternative method. They typically choose to live. I had this experience recently with a 79-year-old patient who requested from me physician-assisted suicide. He gave up on his suicidal plan entirely when he discovered that neither I nor my colleagues at UC Irvine would provide this for him, and when we began to adequately address his family problems. So increasing access to suicidal means by allowing doctors to prescribe deadly drugs will worsen this current public health crisis of suicide. And so reason number 4. Assisted suicide will lead to the medical abandonment of vulnerable individuals, the social abandonment of vulnerable individuals, especially those suffering from treatable mental illnesses like depression or anxiety. What do we hear over and over again from the advocates of assisted suicide? Right? Why do I need this? Fear. People are afraid. These are among the reasons that the disability rights community so strongly opposes assisted suicide. And don't let anyone tell you that opposition to this bill or to this movement is only a Catholic thing or it's only among social conservatives. That's nonsense. If you look at our California Coalition Against Assisted Suicide, it's one of the most politically diverse group of individuals you will ever meet from across the spectrum. So this issue cuts across party lines and typical political divisions. As Father Spitzer noted, we can't ignore the economic forces at work in medicine. We can't ignore subtle pressures that may be placed on individuals at the end of life, such as these gentle and perhaps well-meaning suggestions by family members or by the healthcare system that the person is too burdensome or costly to care for. Right? This kind of suggestion can have a devastating impact on someone who's already exquisitely vulnerable. Father Spitzer mentioned the case of Barbara Wagner. Another man in Oregon named Randy Stroop received the same letter from the Oregon insurance company denying him treatment that his physician had recommended for his prostate cancer, but saying that they would provide for the $100 deadly pill. As soon as we introduce this option into medicine, it's immediately the cheapest form of treatment, so-called treatment at the end of life. It's a deadly mix in a healthcare system that is currently under tremendous pressure to lower costs. Assisted suicide advocates have been claiming that we need this option to deal with situations of intolerable pain and suffering. This is how they sold it in Oregon. But the data from Oregon shows that most patients who request assisted suicide in that state did not cite concerns about pain and suffering as their motivating reasons. Much more common reasons were the perceived loss of autonomy, the fear of becoming a burden on others. Our medical profession, our society, must communicate to each and every patient, you are not a burden. We will continue to care for you even when cure has become impossible. And so, reason number 5, assisted suicide will reduce, not expand, the range of end-of-life options, especially for those who don't have the means to pay for or to access more expensive palliative care or medical treatments. The social consequences of suicide are very significant. Studies have repeatedly demonstrated a social contagion aspect to suicide, which leads to copycat suicides. This phenomenon is known as the Werther effect. It's named after Goethe's 18th century novel in which a young man, the protagonist in the story, who's thwarted in love, ends up killing himself with a pistol. And they noticed after the publication of this book, there was a whole rash of suicides among young men because this book had romanticized suicide in this way, using the very same means as the character in the story. And since then, social science research has repeatedly demonstrated this social contagion effect of suicide. The media violated over and over and over again in the reporting of the Menard case, violated the World Health Organization's ethical instructions for reporting cases of suicide to avoid romanticizing it and to avoid producing copycat deaths. Assisted suicide advocates insist, they claim that this is purely a private decision between me and my physician or me and my family. It's an exercise in personal autonomy. But we can anticipate that these decisions will have social effects that adversely influence other vulnerable individuals. As Father Spitzer already mentioned, it's noteworthy that the overall suicide rates in Oregon rose dramatically in the years following the legalization of assisted suicide in 2007. They were dropping in 1997. They were dropping in the early 90s. Then between 2000 and 2010, they rose sharply. They surpassed the rate of increase nationally, and they're now 35% higher than the national average. I just had communication with a colleague at Oxford who's got a study that will be published very soon looking at the same phenomenon in Washington. The effects of rising rates of suicide in Washington after legalization are even more dramatic than in Oregon. And so reason number 6, the legalization of physician-assisted suicide sends a message that some lives are not worth living. The law is a teacher. The law forms the culture, as we heard already this morning. And so if assisted suicide is legalized, this message is one that will be heard by everyone who's tempted by suicidal thoughts and tendencies. We should be troubled by recent efforts on the part of advocates to redefine suicide. The euphemistically renamed Compassion and Choices claims that what they prefer to call physician aid in dying is not really suicide. Right? And the reason they give is that the means employed, taking a deadly drug, are, in their words, nonviolent and peaceful. Well, of course, by this logic, you'd have to say all the people, the thousands of people that commit suicide every year by carbon monoxide poisoning or by deliberate drug overdose should not also be considered suicide. So this kind of attempt to manipulate language, to do an end run around hard realities, is irresponsible and it's deceptive. And a lot of people are drinking the Kool-Aid. The definition of suicide is clear. It doesn't depend on the particular means that are employed. So we need to continue to call this by its name. And I think actually the most accurate language to describe Senate Bill 128 is physician-prescribed suicide. That's exactly what I do if I write that prescription. And so reason number 7, assisted suicide advocates must resort to language that is deceptive, that glosses over the reality of what is being proposed. People naturally have a repugnance to this when they first hear about it, right? And so there are very creative efforts to make this more palatable to the public by avoiding talking about what's really going on, what's really happening. The proponents of assisted suicide would also have us erase this key ethical distinction that we heard from Father Joseph this morning between allowing a disease to take its natural course or providing adequate palliative care to manage symptoms and directly intervening to deliberately cause death, right? But there's a vast gulf between the ethical act of allowing a natural death and the unethical act of intentionally inflicting death. So Senate Bill 128 is not a modest proposal. It is not one small step in expanding end-of-life medical options. It's not an extension of already existing and legitimate palliative care practices. Not at all. This is a radical departure from sound medical practice. From the ancient Hippocratic Oath all the way to the modern American Medical Association principles of ethics, doctors have publicly promised to use our knowledge and skills only for the purposes of healing, of supporting life. The moment we stop doing this, the moment we use our knowledge and skills for any other purpose, we risk squandering the trust of patients and of society. And so to maintain the public's trust, to maintain our professional integrity, medicine's mandate must remain this: when possible, we cure. Always, we continue to care. We don't abandon patients. But never do we kill. As responsible citizens, all of us, I would suggest to you, all of us need to play our part in opposing this legislation, not only for the integrity of the medical profession, but more importantly, for the benefit of the sick and for the good of the whole society. Thank you all for coming tonight, this afternoon. Thank you for your attention. Let's pray for one another.